So again, the CUA has initiated this type of a program with the intentions to help fulfill this unmet need of urology to urology interaction, and I hope that this does foster that, but as well to allow urologists to discuss various different nuances specific to prostate cancer, as to again thought leaders in prostate cancer treatment and research. Next slide. And again, I'm very happy to introduce Dr. Matthew Smith. He's the director of the GU Malignancies Program. He has authored over 200 papers in the field of bone health, and really was one of the key figures to bring this whole concept of bone health in androgen deprivation, as well as has been the principal investigator for many of the key trials looking at the value of bone-targeted therapy in patients treated with androgen deprivation, as well as those patients with metastatic castrate-resistant prostate cancer. For all of those, I wish for all of you to hopefully put your mics on mute for now. Dr. Smith's talk will be approximately 20 minutes. Afterwards, we will be having a question and answer period. And again, Dr. Smith, I welcome you, and I hope we have a very good and productive interactive session. Next slide, Oris.
We're passing the presentation privileges over to Dr. Smith. Dr. Smith, welcome to the conference, and we'll turn the presentation over to you.
Thank you. And my thanks to Dr. So for the thoughtful introduction, and for the CUA for sponsoring this program. In the spirit of what Ellen said, we do want this to be interactive, and I've prepared a presentation that's intentionally concise in attempts to address a few of the important clinical issues around the issue of bone-targeted therapy. All my remarks will be focused on metastatic disease, most of which will be on metastatic castration-resistant disease. And I'm going to try to make this as thought-provoking as possible. These are my disclosures. And here's the clinical problem. Metastatic prostate cancer really dominates the clinical landscape of fatal prostate cancer. Most men with metastatic prostate cancer have a bone-only or bone-predominant pattern of spread. By plain radiographic appearance, these metastases are described as osteoblastic rather than osteolytic, although we'll talk about some subtleties and important distinctions regarding bone biology in this regard. Metastatic prostate cancer has a particularly high bone turnover, and it has a distinct pattern of clinical complications, including pain, fractures, spinal cord compression, and ineffective hematopoiesis or myelophysis. My aims are to describe the changing treatment landscape for metastatic castration-resistant prostate cancer, to briefly summarize the latest evidence regarding use of bone-targeted therapy in metastatic disease, and focus most of my remarks on the third point, which would be to discuss some of the contemporary controversies regarding management of bone metastases. In other words, what we couldn't learn from the primary analysis of these many pivotal trials. The landscape of management for advanced prostate cancer has been transformed in recent years. There's many ways to represent this point. What I've done here is created a timeline for FDA approvals in castration-resistant prostate cancer. One could construct a very similar timeline for Canadian approvals with a few key distinctions. The drugs shown above the horizontal blue line are those that have been approved based on increased overall survival. The drugs below the horizontal blue line are those that have been approved based on intermediate endpoints, including reduction in pain and skeletal-related events. The first drug approved based on increased survival was docetaxel in 2004. then had to wait many years till 2010 till the next drug approval, and then within just a few years, there were 5 additional drugs approved based on increased survival, including 2 androgen receptor targeted therapies, abiraterone and enzalutamide, a second chemotherapy drug, cabazitaxel, and immunotherapy, sipuleucel-T, and radium-223, an alpha-emitting bone-seeking radiopharmaceutical. Now, I've highlighted it here the drugs that we would characterize as bone-targeted. There are 2 older beta-emitting radiopharmaceuticals, strontium and samarium, that were approved many years ago based on improvements in pain in symptomatic patients. And we have 2 osteoclast-targeted therapies, zoledronic and denosumab, approved based on a reduction in skeletal-related events, a clinical trial endpoint that's meant to represent skeletal morbidity in men with metastatic disease. And then radium-223, which has in many ways changed the way we think about bone-targeted therapy, as this drug not only reduced skeletal morbidity but also improved overall survival in the pivotal trial. Bone metastases in prostate cancer are described as osteoblastic. That's what you'll read in the textbooks. But the biology is more complex. And by that I mean that in men with bone metastases from prostate cancer, there's not only high levels of osteoblast activity, but there's also pathologic activation of osteoclasts. There's a variety of ways to make this point. What I've done here is shown you a scatter plot of individual patients in the baseline evaluation for the pivotal zoledronic acid study. These are men with metastatic castration-resistant disease. On the y-axis is bone alkaline phosphatase, the biomarker of osteoblast activity. On the x-axis is NTX, the marker of osteoclast activity. In that tiny red box in the lower left-hand corner corresponds to normal levels of bone turnover. And you see that virtually all the patients are well outside this box, meaning they have high levels of both osteoblast and osteoclast activity, with most patients many-fold above the upper limits of normal. Pathologic osteoclast activation is not only a characteristic feature of bone metastases from prostate cancer, but it also predicts worse clinical outcomes. Higher levels of osteoclast activity are associated with a greater skeletal morbidity and greater risk of death from prostate cancer. And that evidence that I briefly summarized there forms, at least in part, the rationale for studying osteoclast-targeted therapy in a disease that's typically described as osteoblastic. This concept was validated with the approval of zoledronic acid to prevent skeletal morbidity. This is the design of the pivotal zoledronic acid 39 study led by Fred Saad. The study included men with castration-resistant prostate cancer and bone metastases. Patients who were randomized to either best standard of care plus zoledronic acid versus best standard of care plus placebo. It's worth noting that this study was published in 2002, and that's when zoledronic acid was first approved, and that predated the availability of any life-prolonging therapy. So best supportive care at that time really wasn't much. And we'll come back to that point when we talk about whether this data is relevant in a contemporary era with many life-prolonging treatments. The primary endpoint for this study was skeletal-related events. And as you're all aware, the study was positive compared to placebo. Zoledronic acid reduced the risk of skeletal-related events, and this and other data led to the approval of zoledronic acid in prostate cancer for men who had castration-resistant disease and bone metastases. Subsequently, a few years later, there was a phase 3 study of denosumab, a more potent osteoclast inhibitor, compared to zoledronic acid to prevent skeletal-related events. This was a large undertaking with almost 2,000 patients. The study included men with bone metastases and castration-resistant disease, best supportive care plus denosumab versus best supportive care plus zoledronic acid with the primary endpoint of skeletal-related events. In this study, best supportive care was a little different because by this time, docetaxel had been approved, but none of the subsequent life-prolonging treatments had yet been in the clinic or approved. So this, too, is a more contemporary era, but still doesn't take into account the more recently approved highly active drugs. In this study, denosumab was superior to zoledronic acid with a 18% reduction in risk of events, but with no improvement in overall survival or time to disease progression. These were secondary endpoints of the study, primarily to look at safety, but we see really no trend towards better survival or delay in disease progression. In the United States, at least, with the approval of these drugs in castration-resistant disease, many clinicians began using these therapies in men who were still responding to androgen deprivation therapy, so-called castration-sensitive disease. Recognizing that, we wanted to evaluate whether that made sense, and we designed a randomized controlled trial to address that question. The study looked at men with bone metastases who were within 6 months of initiating androgen deprivation therapy and assigned them to the standard arm, which would have been no bone-targeted therapy until castration resistance, that's shown in the lower row, versus early introduction of zoledronic acid, basically upon study entry, and then continuing zoledronic acid after development of castration-resistant disease. This was a placebo-controlled trial, and the primary endpoint was skeletal-related events, defined in a somewhat more practical manner than the industry-initiated studies. Here are the results of that trial. Very easy to interpret. The lines are completely overlapping, showing no improvement in event-free survival in the between early zoledronic acid versus standard zoledronic acid. This implies, to me at least, that adequate cancer control with androgen deprivation therapy, using androgen deprivation therapy, there's no incremental benefit by early introduction of zoledronic acid, and I would also infer that I presume the same to be true of other osteoclast-targeted drugs. So here, at least, we can say with some conviction that there's no established role for using osteoclast-targeted therapy in men who are responding to ADT, at least not for the purpose of preventing disease-related skeletal complications. Consistent with that observation, for the primary outcome, there was no improvement in either progression-free or overall survival in men who received early zoledronic acid. So what do we know now that there are other life-prolonging drugs approved? So I'm going to focus my comments for a moment on two widely used drugs, abiraterone acetate or Zytiga and enzalutamide or Xtandi. They both target the androgen receptor axis. They've both been shown to significantly improve progression-free and overall survival in both the post-chemotherapy and pre-chemotherapy settings. As part of the development plan for these drugs in the post-chemotherapy setting, skeletal-related events were evaluated with the thought being that would provide confirmatory evidence should the study be positive, confirmatory evidence of clinical benefit. So in the AFFIRM study, time to first skeletal-related events was significantly improved in men who received Xtandi or enzalutamide with a hazard ratio of 0.69. So meaningful reduction in time to first skeletal-related event. Bear in mind, this is not a bone-targeted therapy, it's a AR-targeted therapy, and I take this to mean that better cancer control, it results in reduction in skeletal morbidity. Said a different way, the best way to prevent skeletal events is to provide optimal cancer control. Similarly, in the Cougar 301 post-chemotherapy study, abiraterone acetate reduced the incidence of subsequent on-study skeletal-related events, again making the same point, better cancer control, fewer skeletal-related events. This, of course, raises an important question, and that is, does AR-targeted therapy replace the need for osteoclast-targeted therapy in metastatic disease? And by inference, you might substitute other effective therapy for AR-targeted therapy. These studies were not specifically designed to answer that question, and candidly, it would be quite a large undertaking to design a prospective study to address that question. So what's been done to date is to look back at the data from these completed trials and ask the question of men who entered the trial whether their receipt of a bone-targeted therapy in any way impacted the study outcomes. And these are analyses done by Fred Saad. In the Cougar 301 study, something like half the patients received bone-targeted therapy, the other half did not. Almost all the patients receiving bone-targeted therapy were receiving zoledronic acid. And if you take a moment to sort of tease apart those various subgroups, what you'll see is that the patients who received abiraterone acetate in combination with the bone-targeted therapy had a better overall survival and a greater reduction in need for opiate use compared to those who got abiraterone acetate without the bone-targeted therapy, suggesting that there may be either an additive or a potential synergistic effect between AR-targeted therapy and bone-targeted therapy. Now, there are other potential explanations for this study, but when best efforts were done to look at potential confounders, this seems to hold up. So there may be meaningful interactions between these two classes of drugs, or at least suggest that there is an ongoing role for bone-targeted therapy with effective AR-targeted therapy in this disease state. Radium-223 has also changed the way we think about bone-targeted therapy in men with metastatic disease. Radium-223 is radium is in the same column of the periodic table as calcium, and radium-223 acts as a calcium mimic. It naturally targets new bone growth in and around bone metastases. In contrast to the older beta emitters, this delivers high energy over a short distance and provides greater cell kill. After very promising phase 2 study results, the drug was evaluated in phase 3 with the primary endpoint of overall survival. The study, known as ALSYMPCA, was successful, showing that compared to placebo, radium-223 significantly improved overall survival with a reduction in risk of death of about 30%, putting it really in about the same ballpark as our other life-prolonging drugs. Further, radium-223 delayed the time to symptomatic skeletal-related events, here with a reduction in risk of more than 35%, providing confirmatory evidence of the clinical benefits of radium-223 in this setting. This observation, too, raises the question of whether radium-223 supersedes or supplants the need for osteoclast-targeted therapy to prevent skeletal morbidity, meaning if you're treating a patient with radium-223 with the goal of preventing skeletal morbidity and increasing survival, do you need to administer concurrent osteoclast-targeted therapy, recognizing, once again, that those osteoclast-targeted therapies were developed in an era before radium-223 existed. So this, too, is a question that would be challenging to address prospectively, but we're able to look back in the completed ALSYMPCA trial to try to get a sense for what was happening and whether there is a role for bone-targeted therapy in addition to radium-223. So about 40% of the patients in the ALSYMPCA trial were receiving a bisphosphonate at study entry, and the remaining 60% were not. So as you look at on the left-hand side, the treatment effect in favor of radium was greater among men who were receiving a bisphosphonate at study entry with a hazard ratio of 0.49, so about 50% reduction in risk of symptomatic skeletal-related events compared to placebo in patients who are receiving a bisphosphonate at baseline. We look at the group who were not receiving a bisphosphonate at study entry. There is a significant ongoing benefit of radium-223, but the treatment effect is smaller. Here again, suggesting that concurrent treatment with a bisphosphonate and radium-223 results in better outcomes than treatment with radium-223 alone, with all the usual caveats of a post hoc analysis. So by design, I've tried to be concise so that we have plenty of time for questions, but I'd like to briefly conclude with the following comments. Osteoclast-targeted therapies, meaning zoledronic acid and denosumab, improve skeletal morbidity, but have no discernible impact on either survival or disease progression. The benefits of osteoclast-targeted therapy appear to be retained in the contemporary treatment landscape. Radium-223 increases overall survival and decreases symptomatic skeletal events. A variety of ongoing studies are designed to prospectively address questions about the optimal timing, sequencing and role of combination therapy in metastatic disease. Thank you.
Dr. Smith?
Thank you. Thanks, Dr. Smith. Alan, over to you.
Dr. Smith. Yep. Well, I would now open the question period to all of the participants to ask any questions that you have. And again, you may want to ask Dr. Smith a question that may not even be part of the this discussion tonight. But what I will do is I'll start off the question period with a few questions, and then I hope some of the participants can chime in. So Dr. Smith, great talk, very provocative in terms of the benefits of combination therapy. One of the questions that I often get is, when is the optimal time to actually start a bone-targeted therapy in a patient with castrate-resistant disease? You showed data to suggest that the benefits in terms of SRE prevention is not there in hormone-sensitive patients, but should we be starting patients very early on, the moment they develop bony mets, or do we have time to wait and maybe just give them bone-targeted therapy to prevent osteoporosis?
Yeah, so I appreciate the question. Thank you for doing that. And it really does, it is really worthy of some comment here. So that my prepared remarks really relate to the role of bone-targeted therapy to prevent disease-related skeletal morbidity, meaning the complications due to bone metastases in the patient. The issue of osteoporosis prevention and benign fracture prevention is really a completely separate issue. So my comments about the timing of these drugs relates to really their use for prevention of skeletal morbidity due to disease. And the reason that's important is because the intensity of therapy is quite a bit different. Osteoporosis treatment, is twice a year Prolia, or once a year zoledronic acid, weekly oral bisphosphonates. When we give these drugs, denosumab or zoledronic acid, for preventing disease-related skeletal morbidity, the annual dose intensity is 12 times as high. It's a very different story. So to address the question about disease-related skeletal morbidity, my approach is really to wait till patients develop castration-resistant disease, and in my best estimate, their future risk for events is considerable. I'm not looking for that patient with slowly progressive disease and a solitary metastasis to start zoledronic acid or denosumab. It's really when their disease is advancing and they have a substantial burden of bone disease is typically when I begin to intervene. The trials that led to the approval of these drugs, we have to remember, started with patients who had a considerable burden of bone disease. The median PSA in Fred Saad's original zoledronic acid study were something like 1 to 200. So we can't infer from that we should begin, these drugs when patients' PSA goes from 1 to 2.
That's great. And then as a corollary to that, when you start patients on the bone-targeted therapy for SRE prevention, how long do you generally keep them on it? Is it just 2 years as per the trials, or if they're tolerating it well, will you keep them on it indefinitely?
Yeah, it's another great question. So when to start, when to stop. So the when to stop question is also challenging. And it's more important in the contemporary era because we have better drugs to control the underlying malignancy in patients who are living longer. At the time of the pivotal studies of zoledronic acid and denosumab, the median survival in those trials was less than 2 years or something around 2 years. In the more contemporary era, patients are living longer, at least by many months longer, in some cases years longer. And we don't know how long we should treat. In the zoledronic acid study, the treatment was for a maximum of 2 years, recognizing that most patients died before that. In the DMAB trials, treatment was indefinite. What I do in my practice is don't necessarily completely stop treatment, but I may change the intensity of therapy. This is not evidence-based. It's best guess, candidly. So while a patient's malignancy is under very good control, say they're having an excellent response to Zytiga or docetaxel, I may space out the frequency of their bone-targeted drug from monthly to every 3 months in an effort to do the most good with the least treatment. But that is not an evidence-based recommendation. We really don't have adequate information about tailoring treatment to the underlying disease state or optimizing duration of treatment.
Thank you. Are there any questions from the participants?
Yeah, hi, it's Paul Martin here. Can you guys hear me okay?
Yeah,
Yep.
we can hear you.
Oh, that's great. That's great. Thanks so much for the good talk. I'm one of the urologists from Sarnia, Ontario. So I just wanted a question about the previous question about the role for bone-targeted agents in non-castrate-resistant disease. So, you know, the guys who present with high-volume disease, very high PSAs. Is there any role for that at all, or do we always wait for castrate-resistant disease?
Thank you for your question, Paul. So it depends on intention. All older men are at risk for osteoporosis and fractures, and androgen deprivation therapy further increases that risk. So for a man who's going to be on long-term androgen deprivation therapy, I would encourage you to look at that individual and decide whether he meets criteria for drug therapy to reduce his fracture risk. And that's really kind of a general medicine approach to this kind of problem. Separate from that, if the patient has bone metastases, then there's the issue of disease-related skeletal morbidity. And so in a man without bone metastases, that wouldn't be a current concern. The in-between question, though, is, you know, if we start these drugs earlier, would we delay or prevent the development of clinical metastases? And there isn't sufficient evidence to recommend doing that. This is a study that's been addressed in clinical trials with some limited success, but really there wasn't compelling enough evidence of a favorable benefit risk to recommend doing so. So absolutely, the patient like you described, enthusiastically evaluate him regarding his risk for osteoporotic fracture, intervene according to standard guidelines, but don't treat with the intensity that we would for disease-related skeletal morbidity.
Okay, that's great. Thanks a lot.
Thank you.
Next question, sort of a follow-up. How about, are you doing, how often, if at all, do you check bone density in these men? Is it useful to do that at baseline? How does that fit into your practice?
Yeah, thank you for that question as well. So it's a really interesting, it kind of goes like this. So we have to be careful about not oversimplifying fracture risk based on bone density alone. Having a low bone density puts an individual at greater risk for fracture, but most individuals who fracture do so with a normal bone density. Well, why is that? Well, because most patients have a normal bone density and they still have some risk for fracture. So what I recommend doing is using the FRAX risk assessment tool from the World Health Organization. If you haven't looked at it, go online. It's spelled FRAX. You can plug in, it's a nomogram, you plug in the patient's characteristics, and it spits out an estimated 10-year risk of fracture of both the hip and other site osteoporotic fracture. And if it exceeds certain thresholds, for example, a greater than 3% risk of fracture at 10 years, that patient will be a candidate for drug therapy based on standard clinical guidelines from the general population. And it sounds like a lot what I've just said, but the nomogram takes about 1 minute, and after you've done it a few times, you'll understand it well enough that you can really kind of eyeball a patient and get a sense for whether he would be at sufficient risk to warrant drug therapy. And if you do that, you'll be a long way there to really individualizing treatment for your patients. If you choose to do so, I'd encourage you to get a bone density at baseline or after a few years of androgen deprivation therapy as well, but recognize that the bone mineral density measurement does not supplant the need to look at the clinical features of the patient.
Yeah, thanks so much. That was very helpful.
Thank you.
Are there any other questions? So, Dr. Smith, one question that, again, I get a lot from other urologists is the comment that, and you mentioned this in your talk, the comment that the novel therapies that we have for cancer-resistant prostate cancer themselves proven benefits in skeletal-related morbidity. Notwithstanding the fact that the improvement of the disease in the bone is by the therapy itself, is this enough information for us to say then we can delay the bone-targeted therapy? And is the data of combination therapy strong enough to then say that all those with radium who are on radium-223 or abiraterone should be on bone-targeted therapy?
Yeah, so I'd say this is a good news story in the field that we now have we have a variety of options that are effective, and we are prolonging the life of many of our patients with these drugs, and some patients by many years. The priority should be controlling the underlying malignancy, and that's going to be with those life-prolonging drugs that are enumerated on one of those early slides. So it's, abiraterone and enzalutamide and docetaxel and radium-223. Those are the priorities. So what I kind of tried to ask with some of those provocative questions is, do those priorities push entirely off the table the need to consider bone-targeted therapy? And you've kind of rephrased that same question here. I'd say no, but it's still, they've moved down in priority. So I think we still need to consider that. And I tried to make a case that at least we have some retrospective data to make the case that it does look that the patients who receive concurrent therapy do better. Some of these questions will be systematically addressed. There's an ongoing trial, for example, of radium-223 that will look at Abi plus or minus radium-223, see if early combination therapy results in better cancer control and delay in skeletal morbidity compared to sequential treatment. So that's an important trial. But there are so many questions to ask, many of them will never be asked in a prospective manner. So we're left with good but not completely satisfactory kind of retrospective analysis to address that.
Thank you. Do we have any other questions?
Alan, it's Orith here. I'm not getting any through the chat, so okay. Either the chat function is not working, or everyone's had their questions answered by your first couple, or from Dr. Martin through Sarnia. So I'm just going to unmute everyone for a couple of minutes here, just to make sure that everyone has a chance in case they're not online and maybe they've dialed in or something like that. So right now, everyone is unmuted from an audio perspective. We may have a little bit of background noise as a result of that, but I just wanted to give everyone the opportunity to ask a question if you have it. It'll be first come, first serve at this point.
Well, Paul Palmer, again, I'll ask one if nobody else has another one.
Go for it.
So radium-223, I have no experience whatsoever with it. I have no patients on it. I don't even know if they're giving it in London. Should I be sending patients to it? I've got a couple patients on abiraterone, for example. Like I'm starting to, I guess, dabble into castrate-resistant disease very carefully. How does it fit into my practice from a practical standpoint?
It's a good question. So what we know from Alcimca is that the drug improves survival and delays onset of symptomatic skeletal events. The study included patients who had either received prior docetaxel or who were deemed unsuitable for docetaxel, and that's what we know. We don't know the optimal sequencing of this drug or other drugs. It's very challenging. So at the present time, we take a practical approach and say, for the most part, most patients would prefer to have the oral AR-targeted therapies before chemotherapy. I think why they've been broadly used. Some patients would prefer to avoid docetaxel, and that might be a good place to slot in radium-223 after they've progressed on abiraterone, or consider it after the patient's progressed on docetaxel. I mean, that's the way I'm using it in my practice. It has some distinct characteristics that are worth noting, though, that distinguish it from a typical cytotoxic drug. In the Alcipka trial, patients did not have PSA responses at any appreciable rate with radium-223. And in that trial, serial radiographic imaging was not conducted, so we don't really know if the drug delays radiographic progression. So the patients have to go into that treatment with their kind of eyes wide open, so it's important to educate the patient about what their reasonable expectations should be and what the goals of care are. In contrast to other classic cytotoxics as well, the drug is given for a maximum of 6 monthly doses. So it's 6 doses and you're done. So you kind of want to, the way I think about it, you want to find an appropriate landing zone to get in those 5 months of treatment. So if you wait till the patient's ill after they've had all other lines of therapy, it's probably too late. You're going to struggle to get the treatment in and benefit the patient. And I wouldn't do it too early when the patient doesn't have much in the way of bone metastases, because they probably won't stand to benefit. So in my practice, that usually means either after ABI or ENZA, or after that plus docetaxel.
Yeah, thanks so much.
Are there any other questions? So, Dr. Smith, how does the system work at Mass General? Are the urologists there prescribing these agents, or is it primarily med-onc? Is there a multi-D session where questions like this is brought up?
Yeah, we have a long-standing tradition of multidisciplinary conferences, multidisciplinary clinics. We have 4 days a week. We have multidisciplinary clinics.
Wow.
Seeing patients with GU cancers. I'm sitting in my office now, and those are conducted in the same suite, basically. And we are, some but not all of the disciplines are co-localized. So down the hall in both directions from me are medical oncologists, radiation oncologists, and urologists who have their primary offices. So it's really a terrific arrangement, and you know, my closest colleagues are those who practice in GU, regardless of discipline. Most of that work, I have to say, is focused on early stage disease, you know, new diagnosis of prostate cancer, etc. More of the advanced disease is typically in the hands of medical oncologists, right or wrong. We do have a close working relationship with radiation oncologists, who very commonly services are needed to manage bone pain and other issues that comes up in advanced disease. Our urologists do not manage castration-resistant disease. That's, I think, typical of major medical centers in the United States. It's a pattern of care. It's not the only pattern of care, and there are many other models of care that I think are appropriate. That's kind of the way we practice. In fact, our urologists refer patients who have PSA progression. So I do most of the androgen deprivation therapy, or I should say do more androgen deprivation therapy than any other physician at the hospital for that reason. Probably not like that in most places in Canada, and I would submit probably not like that in most practices in the United States. Yeah.
Yeah, I think the situation in Canada is quite varied. And, you know, people can chirp in, but I think that many of the urologists across Canada are treating at least very early castrate-resistant prostate cancer with either Aviad or enzalutamide and denosumab and or zoledronic acid. Are there any other questions?
One last question, Alan, if you wouldn't mind. Just curious, with those patients who are receiving CRPC therapies with enzalutamide or Abi, a lot of those patients have had previous cardiac interventions with angios and drug-eluting stents. Can you just give me any generic comments to watch for Pradaxa and all these new anticoagulant therapies that those patients are on with respect to Abi and enzalutamide?
Well, I want to be careful here because I would hate to misrepresent the safety of any of these things, but I prescribe a lot of the cancer drugs you just described and have the same issues with the overlap of those patients. So I'm not aware of any major drug interactions with those agents. Not aware of that.
Although you have to be careful with enzalutamide and warfarin.
Correct.
But not the other agent.
Yeah.
Thank you.
one question that always comes up, and I actually had an email from one of the participants who actually asked this question is, Dr. Smith, in terms of one of the limiting reasons as to why urologists or medical oncologists do not, or radiation oncologists for that matter, do not prescribe denosumab or zoledronic acid is the fear of ONJ. Can you just give us a 2-minute summary as to how you would focus on dental care, whether or not you send all your patients to a dentist, and how to maximize dental care during the course of treatment?
Yeah, really good question. So, and this comes back to your earlier question about kind of when to start, when to stop. We want to maximize benefit and minimize harm, and there's abundant evidence that it's cumulative exposure to these drugs that increases the risk of osteonecrosis of the jaw. Another major baseline predictor is basically quality of individual's dental health at the time of initiating therapy. And the wave of kind of ONJ that occurred many years ago was before that issue, before the general issue was recognized and patients were going into treatment with very poor dental hygiene. Despite our vast medical expenditures on healthcare in the United States, that doesn't carry over to dental care, so it is an issue in our practice. So for patients, I personally have a look in the patient's teeth and three questions about their, recency of their dental care. And I will insist that they see a dentist, have necessary dental extractions or whatever care they need before I would initiate treatment with one of these agents. That's, I think, optimal care for cancer patients anyways, because other drugs that we're going to administer put them at risk for serious dental infections, although perhaps not ONJ specifically, but dental infections, chemotherapy, et cetera. These are things that we should be considering anyways, but particularly in those who are going to go on to osteoclast targeted therapy, at least for the intensity we're talking about for us, SRE prevention.
Is there an increased risk of ONJ with the combination of radium-223 and these bone-targeted therapies, or has that not been a signal in the combination?
Not so much. I mean, with the recognition of this as a problem, the incidence of ONJ has really gone down dramatically. I mean, in my large practice of prostate cancer, these are very rare events, and the cases of ONJ that we do occasionally see tend to be very mild cases.
Right. Well, I'll start off with a question that was brought up with the previous session about an hour ago. Questions regarding starting and stopping therapies for both denosumab and radium-223. I get a lot of answers from various different oncologists, urologists, physicians as to when they started. Some start when they're symptomatic, others start when there's increased or high disease burden. Where do you see these therapies in terms of initiation times for both either denosumab or radium-223?
Yeah, so thanks for the question. I'll answer them kind of separately. So we have to think about therapeutic intention. So in the case of radium-223, we really do think of it as a disease-modifying agent. So the goals are to increase survival and prevent skeletal morbidity. Radium-223 is developed, is given monthly for up to 6 doses and not to be repeated or to be extended beyond 6 doses. There's additional studies looking at additional cycles of treatment or retreatment, but we don't, until we have such data, the maximum intended number of cycles is 6. I think the sweet spot in terms of picking when to use that drug is in a patient who has substantial burden of bone disease, they have bone dominant or bone only disease, and probably, at least in my practice, outside of a clinical trial, have probably progressed on at least some first-line treatment for metastatic CRPC. In my practice, that usually means progression after ABI or enzalutamide. So that's comparatively straightforward. I think the questions about when to start and stop the osteoclast-targeted therapies, zoledronic acid or denosumab, are more challenging and more nuanced in a way. The studies, for the most part, looked at patients with fairly advanced disease, PSAs in the 10s or 100s, and a fair burden of disease, also done at a time when we had less effective other treatments. So I'm typically looking to start those drugs when the patients, again, often have either have developed skeletal complications, so secondary prevention, or have progressed at least on ADT and probably on first-line treatment with ABI or ENZA. If they have an extreme burden of bone disease, then I'd be inclined to start it concurrent with ABI or ENZA. When to stop? Challenging. If the cancer is under excellent control, I may space out the schedule, but that's really based on inference from other information, not based on hard evidence. We don't know what the optimal duration of treatment is. When the drugs were developed, survival tended to be short. As patients are doing better with effective therapies, I think that's a more important question than ever.
Thank you so much. Are there any other questions from the participants?
All of the lines are unmuted now, so if anyone wants to either ask a question through the chat, which we can raise anonymously, or just type up and voice your question.
Matthew, do you see, I'm sorry, are there any other questions? Dr. Sorensen, Dr. Wong?
No, not
I guess one of the questions I have, Ron Sorensen, in Ontario and obviously in different jurisdictions, there's going to be different guidelines and approval processes by the government in our situation, who basically pays for these various therapies. And one of the I guess restrictions these days, as I understand it, is that with Solviga, you've got to stop if you're on abiraterone. I mean, these people are already getting usually they may be getting an anti-androgen. They may also be getting an LHRH analog. They're getting abiraterone, and along comes, and they may be getting you know, a biphosphonate as well. And then all of a sudden you're adding something else. Now in Ontario, we've got to stop the ABI if that's what we're using, and convert over. But I don't know whether the same thing is happening in the U.S. or whether they would just continue both, or all of the above.
Yeah, so interestingly enough, in the pivotal, thank you for your question, in the pivotal ELSIMCA study, other hormonal therapies were allowed. But at the time the study was done, the ABI and ENZA didn't exist, so patients could be on ketoconazole, prednisone, anti-androgens, in addition to their androgen deprivation therapy with a GnRH agonist. So I'd say the trial, in a way, addressed the partially, and as part of the regulatory approval of radium-223, the FDA required that the sponsor conduct a large study to address the issue of concurrent treatment with the more active current agent. So there is an ongoing study called ERA-223 that's abiraterone plus or minus radium-223, really trying to get to the question that you're raising, which is there added value to concurrent treatment? But for a number of years, we're going to be, you know, not have that evidence at hand. In my practice, I'm looking for a landing zone to treat with radium-223 because it is different. It doesn't lower PSA. We don't know that it delays radiographic progression. And so from a physician and patient experience, not a lot happens, which is different than the other drugs we use. So I'm looking for a spot where the patient has progression, but not reserving it too late when you're probably not going to be able to get in all 6 doses. So in my practice outside of a clinical trial, I'll often, when a patient's beginning to progress on ABI or ENZA, that's when I'll add radium-223, but I usually add it, not replace. I can understand the value proposition and why in Ontario and other regions that there's a requirement to stop that, although I have to say it's a little inconsistent with the clinical trials because that was allowed in the trial, but albeit not with the specific agents we're discussing.
Alan, you're familiar with the Canadian system. What do you think when and how we should initiate Solviga in the whole process?
Yeah, so that's a great question. I think from the BC perspective, we're actually behind a lot of the other provinces. So for instance, bone-targeted therapy in the SRE prevention sense is only approved in patients who are in the Plan T, which is called the palliative care program. So in essence, it can be only started when they have 6 months of survival. So it actually really limits our ability to use the therapy. Where it comes to radium-223 Xofigo, we are seeing a dramatic increase in its use, but you're absolutely right. Unfortunately, all the patients who are eligible for it have to be off of any other novel therapy, either abiraterone or enzalutamide. So I completely agree with Matthew that it's not necessarily the reason to stop the therapy, but again, the only indication right now in British Columbia is if they are progressing on abiraterone. So at that time, they would discontinue it, rather than the other indication where there's potential clinical utility even while on therapy per se. So you're right, it's a challenge, and with all these therapies costing so much, the government is restricting all of our use, and it's also challenging from a guidelines perspective because the Canadian Urological Association is trying to promote the best and optimal care, yet oftentimes it's not met with what is reality, just like you're saying, Ron.
And I think that's well stated for sure. I didn't realize it was that difficult to get them on bone targeted therapy out in BC. Yeah. I can understand with the large influence and radiotherapy that Xofigo would probably enter in earlier in the whole scenario, which is a good thing. Yeah. I guess one process in Ontario is that we cannot give Xofigo unless the patient is truly symptomatic. In other words, they've got back pain or something. Although, I mean, you could probably play that one out. Somebody's got big back pain that may have nothing to do with prostate cancer, but,
Yeah, that was Ron. That was the exact same question that was brought up from another Ontario urologist in terms of the pain. He was very confused about the indications of the initiation of radium-223, but as Dr. Smith stated that pain is not necessarily the best clinical indicator to actually start treatment.
Exactly. But as I say, I suppose you could probably bend the rule a little bit. Somebody gets pain in their wrist.
Yeah, no, you're right. Good points, Dr. Sorensen. Any other comments, questions, Dr. Wong?
No, we're good.
Okay. I guess my last point with Matthew Smith, Dr. Smith, would be just to kind of give us his perspective as to just practical points of initiation of therapy. I guess my two-part question for that then is, what is your dose of calcium and vitamin D that you would give? And secondly is just a quick description of your perspective of dental care and your screening for dental care and hygiene, which for all of us is quite difficult, especially when we're so worried about ONJ with these therapies.
Yeah, really practical questions. Thank you. So the osteoclast targeted therapies should be given concurrently with supplemental calcium and vitamin D, and the purpose of that is to prevent symptomatic hypocalcemia or low blood calcium as a consequence of treatment. The standard dose is 500 to 1,000 milligrams of calcium, and then vitamin D, I recommend 1,000 to 2,000 international units per day. It's a little more than was used in the trials, but that is more consistent with the recommendations to prevent bone loss in the general population.
Is that supplement or is that total dietary calcium and vitamin D?
Yeah, so the vitamin D is definitely a supplement. The issue with it, when used to treat patients with metastatic disease, I do recommend supplemental calcium. In a perfect world, you'd actually be assessing daily dietary calcium, or not on a daily basis, but you would assess their current dietary intake. It gets to be a little bit unwieldy. That's, I think, more relevant in the chronic setting for patients looking at osteoporosis, where ideally you get adequate calcium intake from your diet. And just worth getting on my soapbox here, that doesn't mean eating more ice cream and milk and cheese. The dairy industry has won here in convincing everybody that that's the only source of calcium. It's simply not true. Plants are an ample source of calcium. As a vegetarian, I'd like to point that out. The other point that I think you brought was the ONJ one, which is really important. And it's a problem that's been greatly reduced by recognition and good preventative practice, and also better management of the problem when it does arise by dentists and oral surgeons. So big picture issues: assess patient's dental health before starting one of these agents. If the patient is not receiving regular care by a dentist, it's really important to get them to see one and deal with any, necessary dental extractions or other invasive procedures that may be required as part of their routine dental care that perhaps has been missed. So it's sort of a teachable moment about dental health. And then great care in evaluating any dental complaints. Fortunately, I think the community is very well educated about this. Dental community is very well educated about this. So many of the problems of the past have been reduced greatly just by that information.
How long do you usually leave somebody off denosumab when you're, or any kind of biphosphonate therapy when they do run into the problem?
Depends on its severity and also what's going on with their bone disease. So fortunately, the problem in my practice has been greatly diminished by the issues I raised, just sort of recognition of the issue, better dental care up front. For many of my patients, it would be permanent discontinuation. There is some experience with retreatment. It seems to be okay, but again, these are very selected examples, so we would hope good judgment went into the patients who were retreated, and so they did okay because they were well selected. I think mild cases of ONJ in a patient with symptomatic extensive bone metastases would be reasonable. In the few cases of ONJ that I've seen, I've typically never retreated the patient.
Does the same go for oral biphosphonates too, or?
Well, the risk of oral bisphosphonates, because the intensity of treatment is far less, is very, very low. So when these drugs, bisphosphonates or denosumab, are used for fracture prevention, the dose is less than 1/10 the annual exposure when we're treating for preventing disease-related skeletal morbidity. And when used for in osteoporosis dosing schedule, the risk of ONJ is close to zero, approximately zero.
So if somebody ran into a problem with a dental abscess, tooth, or whatever, and they managed to get that corrected, would you restart them, or would you put them on an oral?
Oh, yeah. Sure. So yeah, I mean, dental problems. So if you're referring to, I mean, the patients I've discontinued or interrupted would be if they truly have ONJ. If they just need dental surgery, typically they just have their dental surgery and resume once they've adequately healed. So that for a typical patient might mean they miss a dose or two.
How long do you keep them on? Forever, or do you stop at 1 year?
Well, as I like to say, forever is a long time, but unfortunately it's not long enough for many of these patients with fatal disease, right? So it's a nice problem. It's a good news story. It's a nice problem to have, the outliers who are living for many years. There I typically will tailor the schedule. I won't stop them entirely, but if they're doing very well, their cancer's under good control, they've had a year or two of monthly treatment, I'll space out the schedule to really conform to their oncology follow-up. If they're doing well, their cancer's under good control, and I need to see them in 3 months, I'll space their denosumab or zoledronic acid schedule out to every 3 months. Well, that's a practical accommodation, not based on evidence.
Right, and as we know, patients are more likely to be compliant if you do sort of work with them rather than sort of trying to get them in monthly forever.
I think that's right.
I look back at some of the days when LHRHs were administered every month, and I don't know how I ever could keep up.
It is hard to imagine, isn't it?
It is. Alan, you don't have to worry about that.
It's true. Although Firmagon's monthly, so.
Well, that's true, yeah. Yeah.
Well, that's great. Thanks, Ron. Are there any other questions at all? Just want to thank Dr. Smith. It's quite late, and I do realize he's at work still. So kudos to Matthew Smith to staying up for us. Thanks so much. It was a great talk.
Yeah, absolutely.
Great interactions.
You always learn something new. That's for sure. Thank you very much, Dr. Smith.
Glad to be able to do it.
And Alan.
Thank you. Thanks.
Thank you, guys.
Here's the upcoming WebEx meetings. I really do encourage you to join in on these. You know, the first, at least the first and third sessions appear to be on DTAs, but again, I think it's going to be nice to have a different perspective on this. Dr. Smith presented an academic perspective. Drs. Palmerville and Zadro will be looking at it from a community urology practice. In terms of advanced prostate cancer management from a med-onc and a uro-onc point of view, we'll be presenting that on February. And in March, Dr. Sad and Fletcher will be leading a research project that we have completed on data utilization of OTAs in community practice.
Wonderful.
Next slide. And again, thanks everybody. This is an accredited WebEx series. I know that there are some users or call-in people who did not put in their names. Please email ORIST or the CUA Office of Education and let them know that you participated in this program to get your credit. We've been taking down attendance, so we are unable to take your attendance if you don't give us your names. There will be a evaluation form sent to you, and I really would encourage you to send me an email or the Office of Education an email in terms of topics that you want us to discuss. Hopefully this is an ongoing program, and we target various different aspects of prostate cancer, hopefully in the future, other GU oncology. Again, thank you, everybody.
Is Tal the contact person down there for?
Tal is a contact person, absolutely. Yeah. And she will be
mailing
out your certificates.
I can say very, very accommodating and really took care of me today because I couldn't make the 7 o'clock one, so got me rescheduled at the last minute for the later one.
Oh, that's great. Thanks so much.
We will pass that along, and so that brings us to a close of this session. Again, it's